Hi, I'm Dr. J. Varma, and welcome to Thermometer. On this channel, I check the temperature of health in the United States and around the world and give you expert insights on public health and infectious diseases. This is our weekly episode of Inside Outbreaks. And on these episodes, I review the latest outbreaks of infectious diseases, the outbreaks that you need to know about. And I do this with my friend and colleague, Jon Epstein, a veterinarian, virologist, and disease ecologist who, like me, has spent his career tracking dangerous infectious diseases across all corners of the earth. Thanks, Jon, for joining me today.
Thanks for having me, Jay.
Good. Are you hanging in there? I know we talk a lot about climate change, and I think for those of you who are watching from the Northeast, you can feel the effects of climate change right now.
We're in the midst of a massive heat wave, and it's always this battle psychologically that, okay, we've had hot days in summer before, and it's not even, funny enough, record setting. I mean, we're going to have something like 95 or 97 degrees today that's going to feel like 105 or 110 apparent. So it's humid, it's hot, and it's June. And I keep thinking like, okay, I know it's not normal, but how much worse will it be down the road? Are we going to have months of this in 10 years or, what? And how do we really prepare for it? So yeah, it's not just a hot day. It just gets my brain cooking.
Well, it's interesting because, you had mentioned to me about how your kid's school is going to be closed for the heat. And I keep thinking to myself, I fought these school wars during COVID. I was on the side of getting schools open, safely, but getting kids back to in-person learning. And it's interesting. I now pay a lot of attention anytime I hear about schools closing. And I wonder, where are the protests right now? Are there people in your community protesting the closure of school because of heat?
There's a lot of grumbling, but at the same time, there's a couple of school buildings and they don't all have air conditioning. And so I think deep down, I mean, who are you going to complain about sending, your kid home from 100-degree day with no air conditioning? I mean, that's rough. So yeah, it's hard, but we're in the last week of school. So, either way, it's on to summer camp.
Okay, from snow days to school days. That's right. So now I wanted to start this week. Actually, you even recommended this as well. We always now want to try to do a little bit of good news as part of we spend a lot of time talking about doom and gloom here and risks you need to worry about or manage. So let's talk about something new. So there's some good news about HIV prevention. For decades, since the identification of HIV as a cause of AIDS in the 1980s, researchers have been trying to develop a vaccine for HIV, but none of those efforts have succeeded. And HIV is one of the most challenging viruses to deal with because of how it incorporates itself into human cells and finds ways to hide out from antiviral treatment. But now there's a new drug that may have a lot of the benefits of a vaccine, and it's called lenacapavir. So, before we sort of jump into this little bit more, Jon, why don't you tell us a little bit about HIV? Why is it such a dangerous virus? Kind of gave a little bit of a lead in there.
Yeah, well, I think one of the challenges, and really we talk about all kinds of infectious diseases on this show, but this is really the ultimate pandemic we're dealing with. And by the way, it's zoonotic. So, hard to talk about HIV without starting about where it came from, which was great apes, chimpanzees, and emerged in human populations. And then has been so successful, as you say, because number one, it's a chronic disease. Number two, it attacks the immune system. So the virus hangs out, and really what ultimately kills you is the immune suppression and then succumbing to a secondary infection, right? And so, and the third is that it's transmitted sexually, it's bloodborne transmission. So it's got a number of ways through which it can, spread, intravenous needles. And of course, the sex trade, which is global. And so once it started spreading, it became really hard to contain. And without any treatment or therapy or vaccine initially, it just spread unabated, and all the public health effort was really in prevention. But as we know, when prevention has to do with, prophylaxis during sexual activity or, abstinence is always a tough one. So the public health approaches have been challenging because it's really hard to control people's, sexual habits.
Yeah. And I think, so two things that I wanted to riff off of that you talked about is the first is, yes, I think a lot of people are unaware that HIV really is the perfect example of the dangers of spillover. When I used to serve overseas and, would host congressional delegations, I would try to make the case that say, look, the work we're doing is protecting Americans in long runs. And so just use as an example what would have happened if we had intensive programs around the world to detect the early emergence and to control diseases at their source. HIV spilled over from, apes into humans sometime in the early 1900s. We have really good data from, molecular clock analysis to indicate that. There's a lot of really good anthropologic data that helps to document how this emerged in Central and West Africa, how colonialism, the invasion of the Congos by the Belgians, helped accelerate its transmission to humans.
And so Jay, we should sorry to interrupt you, but we should be specific here. The spillover occurred through bushmeat hunting. So butchering and consuming meat from great apes, from chimpanzees in particular, was what exposed hunters and communities to this virus that used to be just restricted to chimpanzees.
Yeah. And so that's something I know that, Jon, you've worked on a lot, because we worry not just about this retrovirus, but future viruses as well, right?
Sure. I mean, you think of this is one of the major pathways we talk about when we think about viral spillover, and that is contact with wildlife in ways that exposes us to their bodily fluids. And, hunting and butchering, which is something that happens all around the world. I mean, we eat game here in the United States. It's the same concept, but it does put us at risk for whatever viruses that animal may be carrying that have the capability to infect people.
Yeah. And then once HIV spilled over, you pointed out a number of the different ways it can get transmitted. But I think one of the things that's really important to think about is what makes this virus also additionally dangerous is the fact that when people get infected, they have a kind of they have a flu-like syndrome that is very nonspecific. But then after they recover from that, the vast majority of people have no symptoms for years, 5 to 10 years later.
Right.
And so that is a 5 to 10 year period in which they are walking around and can easily transmit this infection to other people.
Point.
So when you and I, talk to people about viruses and diseases, they often worry about the ones that seem acutely deadly, the Ebolas or rabies, things like that. But HIV is like COVID was at the beginning. The fact that it can spread from somebody who has no symptoms actually makes it far more dangerous in other ways. And it has the added side effect of also being a virus that is 100% lethal if you don't get treatment for it. So it has a very long incubation period where you can be spreading the virus, or not sort of incubation period, a long asymptomatic infectious period where you can be spreading the virus to lots of people. And then once you spread it to people, if they don't get diagnosed and treated, they will 100% likelihood die.
In fact, and that's why it was such a breakthrough, wasn't it, when this combination drug therapy, AZT, right, was created so that it prevented HIV from progressing into AIDS, which was the actual disease syndrome that people would develop, right, after that 5 or 10 year period.
Yeah, so the development of basically antiretroviral therapy, initially with single drugs, and then the recognition, of course, that because this virus in particular, almost all viruses, but this virus in particular, mutates so rapidly that you needed to hit it from multiple different targets at the same time to control it. That was the real breakthrough and revolution, the advance in, to advance the entire field of virology for a whole range of health conditions, and that became, proven sort of in 1995, and then it became more widely available than in the US in 96, but didn't really become available throughout the rest of the world until the mid 2000s. And that combination antiretroviral therapy also, a number of us used to want to intuitively believe that this would also have some impact on prevention, but that wasn't really proven until the 2010s with a very large and important clinical trial documenting that not only do you want to treat a person to improve their life, to reduce their illnesses and to increase their life expectancy, treating people also prevents them from being infectious to other people. And so this has been really the great advance in HIV, is the shifting of the model away from purely focusing on changing people's behavior, right? All of us have behavior, and sex is one of the biggest drivers, right, of human behavior, that it's very difficult to get people to reduce their number of sexual partners or to wear condoms or to make sure they're always getting tested. But it's quite a bit different if you can get people treated, and then by treating them, they benefit themselves and you benefit the population.
And Jay, this is a big deal too, because HIV is also vertically transmitted, right? So babies who are born to mothers who are HIV positive would also be at risk of acquiring the virus and then developing infection. So also this treatment was protecting hundreds of thousands, millions of children, right?
Oh, without question. And this is actually one of the first examples of which, actually, you point this out, this was actually the first proof of concept that treating an infected person can prevent transmission of the virus to somebody else. And this is the original trial. When I moved to Bangkok in 2003, this trial had only recently been completed there. It's called the Bangkok AZT trial. And it was a trial of giving mothers who had not because most people in Thailand at that time, where there was a raging HIV epidemic, didn't know they had HIV, and they would present at delivery time. And it turned out that giving those mothers AZT before or even during delivery dramatically reduced the risk of transmitting HIV to a baby. And so, as you point out, that was the first important proof of concept that these drugs don't just help the mother, they actually help the mother being less infectious to their child.
Yeah, that's huge. And so now, one of the big breakthroughs in medical science is this potential. Now, is it a vaccine or is it a prophylactic treatment? What are we talking about here?
Yeah, so here's where things get really interesting. So at the same time in the 2010s, when there was the first large trial showing that drug treatment of people with HIV would reduce their risk of transmitting to their partners, it became a phrase that I use every day when I work in my clinic and when I do public health work, which is undetectable means untransmissible. Okay, so that means if you have no detectable virus in your blood using PCR tests, and that happens because you've gotten the drugs to treat it, they've dropped the virus level to the point it can't be detected. If you are undetectable in your blood, you will not transmit this infection to other people. Right. So that also became the proof of concept to say, hey, can we also give HIV drugs to people who don't have the infection to prevent them from ever getting this? And at the time when this was proposed, I have to admit, I was a little skeptical. I was like, wait, you want to give me HIV drugs so that I won't get HIV and then have to take HIV drugs for the rest of my life, right? It's kind of counterintuitive, right? Isn't the point of avoiding infection so you don't have to take the infection? But it turns out, again, what we call pre-exposure prophylaxis, first of all, it requires fewer medications. Second of all, those medications are very well tolerated. And third of all, the advantage is you don't have to take them for life, right? There may be periods in your life where you have a lot of sexual partners and your HIV risk is higher. You can be on PrEP then. And there may be times in your life that you're not, and you don't have to take PrEP. So the large clinical trials in the 2010s was showing how giving first originally a single drug and then a combination of drugs, tenofovir and the two different formulations of tenofovir, and then giving it in combination with another drug called emcitriptine, that those two drugs together in a formulation called Truvada was highly effective, like over 99% effective at preventing people from getting HIV. So you don't have HIV, you take this medication every day. But the challenge with it, as I just mentioned, is that you have to take it every way. Yeah. And so that brings us to this latest innovation, which is lenacapavir, which is an injectable form of the drug that can prevent you from getting HIV. And I'll just point out that we already have an injectable version of pre-exposure prophylaxis. It's known as cabotegravir. It's given in combination. It's two drugs that are given together. And I give this in my clinic. You can usually give it every 2 months to somebody, but it does require somebody to come in every 2 months, which is a lot of visits. Yes. But lenacapavir, the current version that's been approved, may only require injections once every 6 months. And there's enough early data indicated that it may only need to be given once a year.
That's amazing. So it is still in the category of pre-exposure prophylaxis, and you have to continue to take it, but that makes it much more likely someone's going to comply if they only have to come in once or twice a year to a clinic to get the injection.
Yeah. And this is a breakthrough, right? Right now, when I'm in clinical medicine, I try to get all my patients to come in sometime between August and October every year to get their flu shot. What if I could do the same draw and their COVID booster for the winter? What if I could now do the same thing for HIV prevention? Hey, it's time for your annual visit or your every 6-month visit, and come in and get your vaccines and come and get this injection to reduce your risk of getting HIV. And it really raises the question actually about whether or not we're going to need an HIV vaccine, right? And an HIV vaccine is really, really important because it can give you theoretically give you lifelong protection, but maybe you can get the same level of protection by getting an injection once or twice a year.
Yeah, and not to split hairs here, but in terms of the epidemiology of HIV, it'll be interesting to know if below detectable levels means zero virus or below detectable threshold of a test, because you want to suppress it so that people don't develop disease, but could they transmit, or is this going to completely block transmission? And is it low enough levels that the virus eventually is going to go away from the population if theoretically, right, we had enough coverage?
Yeah. So this is an excellent point here, right? Like, so there's basically one strategy to control HIV, the one that we as the global health community and clinical community have been pursuing, since the 2010s, since these two trials, one that showed giving drugs to people with HIV stops them from transmitting it, and giving drugs to people who are at high risk of HIV prevents them from getting it. We shifted to this biomedical model that the way to control and to stop the HIV epidemic is basically take everybody who is infectious and make them non-infectious, make everybody who is at risk resistant essentially to getting infected, right? And that is the strategy. Now, the challenge, of course, is these are often marginalized populations, right? These are often people who don't have the greatest access to healthcare. Their sexual practices and behaviors are often highly stigmatized. They're illegal in many places around the world. And so it's challenging to do that, right? For a disease for which people would have no shame and no stigma with declaring that they're at risk or that they have it, this type of intervention can work, but finding and getting that to people is the challenge. So anything we can do to make that easier is going to actually help us control the epidemic.
Yeah. And then I think this brings us to the elephant in the room also is this is an amazing breakthrough. And like all breakthroughs, will this be accessible in places who need it the most, i.e. Africa in this case? One of the greatest public health interventions ever is PEPFAR, right? The President's Initiative on Preventing AIDS. And it is under threat right now. I don't know if it's been completely canceled or much diminished, but are we going to be able to get this treatment, this prophylaxis to communities in low and middle income countries where it could have huge impact?
Yeah, I'm really pessimistic about this because what really drove access to HIV around the world was the efforts of the US government to basically establish programs in what ended up being kind of over 50 countries around the world through PEPFAR to make treatment the cornerstone of US foreign assistance for HIV. And that initiative brings with it buying power to drive the price of drugs down. And it has the salutary effect of getting other places around the world to make access and to build upon those programs. So, right, if you're the first investor into a company, that brings in other investors. The same is true when it comes to public health. And when the US pulls out, especially abruptly, like a phased reduction makes a lot of sense from the sense of, building, collective responsibility around the world for public health. But pulling out abruptly makes no sense at all. And to get to your point that you raised earlier that I didn't actually answer about, undetectable levels of virus in the blood, the test basically performs at the level that gives us public health information. You are exactly right. This virus continues to hang out in sort of protected spaces in the body, which is why it has been so difficult to say cure HIV. That is to say that you never need to take drugs again.
Right.
But the blood tests are very good for the public health message of saying, hey, actually your virus, because we can't detect it on this test, it actually means you can't infect other people. It's actually the similar message that I give people about antigen testing, home antigen test for COVID. I say, look, this isn't a great test to say whether or not you have COVID, but it is a really good test to say, do I have enough COVID in my respiratory tract that it'll transmit to other people? Yeah. So this gets back to this question of, I'm very pessimistic about whether the US is going to be able to support this access, and without other countries, whether we're going to have it. And it gets back to this question I raised before of, do we need a vaccine? The advantage of a vaccine is that it's theoretically something that you could give lifelong. And the other advantage is once you have that intervention, you don't need to keep finding people and worry about, do they still have insurance? Do they still need an injection? And it also protects you during times when you don't know you could be at risk. And this is particularly important for women around the world who are subjected to sexual violence, right? And they don't know they're at risk of HIV until they get attacked. So a vaccine has really important long-term public health benefits because it could ensure access in places where you're not going to ever be able to, get people to get injected once or twice a year. And number two, it would protect people when they don't know that they are potentially at risk.
It's such a good point, and it's a really important distinction. This is a massive breakthrough in terms of the medical treatment of HIV and prevention. So it's going to impact epidemiology, but it's not quite the same as a vaccine for the points you mentioned. And so we still have to strive, don't we, towards getting a vaccine that's going to offer some long-term immunity against HIV as a preventative in any circumstance where you don't have to report to a clinic. You don't have to know you're at risk, but it's going to protect you regardless.
Yes. And this is, again, where unfortunately I'm trying to make this a good news story, right?
I didn't want to bring it down, but we're here to talk about these issues.
And it's going to be transformative. And there are ways in which it almost certainly there will be, efforts to produce generic versions, patent fights, all those types of things that I have to believe will hope and create access in the future. But I do worry about the future of vaccine research for HIV because you have a couple of things. First of all, the US government has been the largest single investor in HIV vaccine research. That has essentially gone away. NIH has suspended those studies, is almost certainly not going to continue them because what do these studies focus on? They focus on patients who are a lot of them are gay and bi men. They may be people of different genders. And that's basically, this administration has essentially said, screw it, we're not going to study or help those people anymore. And it's global health, right? Another area this administration has said they don't want to support. And the science is insanely hard. And it's literally like a moonshot. And so I think because of how difficult it is to do and because of the populations, I'm pessimistic about the future of HIV vaccine research. But we can always try to be hopeful too, right?
Look, we got to take this year by year. I mean, we're starting to understand the landscape now with this administration, but, things are dynamic and fluid. And then there's Europe, which is another potential, powerhouse for scientific innovation that is starting to step up. And so I don't know if it's a total, outage of effort against HIV. It's certainly a big hit in the global health scheme, but I'm going to choose to stay optimistic that we'll get back in the game. And certainly this breakthrough that we're talking about is a really important one. It's going to do a lot for US public health and ultimately global public health. And I'm curious to see if this is the kind of thing that the pandemic accord deals with, which was really a treaty amongst, all the countries in the world but us that's going to, try to gain more equity in terms of distribution of vaccines and treatments. And certainly HIV qualifies as a major, major pandemic. So let's see what happens.
So the European transition that you just made is important because the second and last topic I wanted to touch on today is about a disease that has resurged in Europe. And this is a disease that most people have probably never heard about called diphtheria. And European countries in 2022 saw a really rapid increase in diphtheria cases. And there's now a new study out showing how this vaccine preventable disease resurged in Europe. In a multi-country study that was published in the New England Journal of Medicine, European researchers retrospectively went back and did an analysis of the genomic profile, basically looking at the genetic makeup of diphtheria strains from 10 different countries that were affected by this outbreak. Now, most of these infections were in the skin. Diphtheria is an infection. Yeah.
Can I interrupt you? My light just went out. I'm sorry. Can I fix it? I don't know what your editing ability is for this, but
I'm not going to be able to fix it. I don't know what's wrong. John, are you in a blackout? Did the heat wave hit?
No, I'm just an idiot. And I depended on the battery to stay on the light bank. I didn't plug it in like I normally do. And I thought it would last for the show. And I found out the limit of the battery life. So I'm going to plug it in right now, but it's enough of a difference that I was like, shit, if we're starting a new segment, I thought maybe we could do a little magic splicing there.
Well, we'll see. I'm not so good at editing, so we'll see how we go. Go ahead and plug it in. And I'm going to just give the background here for our viewers and anybody who's watching. This is why you're watching professional epidemiologists and public health people, but amateur video and audio people. So most of the infections that occur from diphtheria are actually skin infections. In fact, it's a bacteria that lives in the environment. It's very possible to get a skin infection, but you can, in fact, and this is where the infections get dangerous, get infections in your respiratory tract, particularly in your throat. And so in this outbreak, most of the infections occurred in the skin, but some can occur in the throat. And it turns out the outbreak largely affected young male migrants from Afghanistan and Syria. And these are places where, of course, the countries have been damaged by war and decimation of infrastructure. So there's very little vaccine coverage, there's delayed diagnosis, and of course, there's unsanitary conditions where people can get exposed to this bacteria. And these researchers showed how essentially the bacteria, diphtheria infections, traveled along the path of these migrants from those countries, Afghanistan and Syria, to Balkan countries, and then eventually to parts of Western Europe, Australia, Belgium, France, Italy, and then even Northern Europe, like Norway, and then eventually even across to the United Kingdom. And so the reason that we worry about diphtheria is because though it can be a common infection, it can also have a toxin in it. And that toxin, if you have a toxin-producing strain of diphtheria, can be deadly. And it caused massive outbreaks in the former USSR after the Soviet Union collapsed.
Yeah, and this is I was looking up some statistics on this. Prior to there being a vaccine for diphtheria, we used to have 15, 20,000 cases in the United States, right? And then with the advent, this was, I guess, prior to the 40s, and then when the vaccine came around, dropped to like very few, less than 20, less than 10. I mean, we just really controlled this disease here.
Yeah. And, one way the disease is controlled is by hygiene. If you're not exposed to dirt, you won't get it. Respiratory transmission occurs, but people are exposed to antibiotics. We'll talk about treatment in a moment. And some very standard antibiotics can actually prevent this infection. And then the last and most important way is the vaccine. People get the diphtheria pertussis vaccine, the DPT vaccine, diphtheria pertussis and tetanus vaccine. And that vaccine is highly effective. Mm-hmm. But this is where the worry is, right? As you bring down vaccination rates, you increase the likelihood of people getting this infection. And the more infections with diphtheria you get, the more likely you are to get a toxin-producing strain of diphtheria. And these toxin-producing strains of diphtheria are deadly. They will essentially either suffocate you to death because they cause so much inflammation in your respiratory tract, or they'll spread throughout your body and cause toxicity to your hearts. And this is what happened with the collapse of the Soviet Union. As the Soviet Union collapsed, its incredibly good immunization program collapsed as well, too. And people were in situations where this disease could recur. And this is one of my sort of disaster scenarios for the United States, that with the decline in vaccinations, that we see a resurgence of deadly diseases like this, even though there is a safe and effective vaccine available.
Yeah, and let me be more accurate and more specific in these numbers, because I went looked at the CDC website about this. Prior to the vaccine in the 1920s, we had 100,000 to 200,000 cases in the United States with 13 to 15,000 deaths every year. So not an insignificant disease. And then after the 1940s, when we started having the diphtheria vaccine, the cases rapidly declined until, in the 90s to present, we had, less than 20 cases and only about one death a year. So that is dramatic. And that just illustrates to me how effective vaccine programs can be. And to your point, when those start to go away, it doesn't take long for infectious diseases to rear back up in numbers.
Yeah. And this is, I think, the message that we keep trying to send, like the speed. It's very hard to predict what the tipping point is, right? What the point is when these diseases suddenly recur back. We have statistics to do that, but outbreaks are we can predict that an outbreak will occur. We just don't know when it will actually occur. And that's where I worry about it here. And now this is an infection, as I pointed out before briefly, this is highly treatable. Almost all cases of diphtheria infection respond to, common antibiotics like penicillin and amoxicillin, or if you have a penicillin or amoxicillin allergy, you can get a drug called erythromycin or similar types of drugs. But one of the things they found in this study that was done in the New England Journal is that some of the isolates had indicators of resistance to these commonly used antibiotics. And so this is, again, the concern. One of the reasons we have vaccines is obviously to prevent people from getting sick and from dying. But the other reason we have them is to actually prevent the emergence of drug resistance, which can make these infections highly, even more dangerous than they already are.
Yeah, it's like a recurring story about infectious disease. We worry with a bacterial infectious disease. We worry about drug resistance. We worry about the lack of research and development of new antibiotics and new treatments, so that some of these classic diseases start to be a little less fightable if we don't have enough tools in our arsenal in terms of antibiotics. So that's why it's so important to prevent them in the first place. If we only rely on treatment, then resistance has more of a chance to develop, and we're going to put ourselves in real trouble. So we need the combination of preventing the disease through vaccines and reserving treatment for when we absolutely have to.
Absolutely perfect segue to the end of our show. We started talking about HIV, and we talked all about how prevention, the advent of incredible miracle drug for prevention, but also the joy of and value of treatment, and why prevention is so important. And we talked to diphtheria, same idea. We need to prevent these so that we don't need to use our reserve drugs actually for treatment. And so, I think that's a common message that we have throughout public health. We want to prevent, in your world, we want to prevent actually even before the infections come into humans.
Sure.
But in my world, we also want to steel up the defenses of humans and our ability to treat them. And so if you like learning more about prevention and treatment and how to, basically keep ourselves safe and productive in a world like this, please share this episode with people in your life. Hit subscribe. The more subscribers we have, the more this message can get to other people. And try to educate you more about the world of public health and infectious diseases.
Yeah. And please leave comments. If you have topics you'd like to see us discuss on this show, or ideas, or even a response to something we did mention, we'd love to hear from you. So when you're watching, please feel free to leave comments and let us know what you think.
Great. Thanks a lot, John. See you
All
next
right.
week.
See you, Jay. Thank you.